Spread of oral infections. We know odontogenic infections are the commonest infections seen in humans. They are arising because of any dental infection, either a periapical infection or a periodontal infection. What happens is once the periapical infection extends to the periapical region, it just tends to spread and involve the underlying bone. So once it involves the bone, it because of extensive inflammation, the inflammation it just tends to involve the surrounding surface, the soft tissues, and the infection it just tends to spread along the facial spaces, ultimately leading to cellulitis or extreme spread of the infection. Usually the spread of infection, as we know, it occurs either by the lymphogenous route, that is the lymphatic route, or a hematogenous route. Blood may be the common factor, or metastasis of the organisms from one side to other side. It may lead to spread of the infections, or bloodstream, the commonest route for transmission of microorganisms from one side to other side. All these factors, they help in spreading the infections. So dental infections or periapical infection or periodontal infections, though they may be minimal in appearance, they, when involving the bone and the skin, they just cause rapid devastating effects to the humans. So we'll study how the oral infections, the odontogenic infections, they spread and involve the surrounding tissues, and how the spread actually occurs. Okay, the significance of oral focus of infection, or the oral foci of infection. We'll be dealing with the cellulitis, Ludwig's angina, and the infection of tissue spaces, how the infection spreads along the tissue spaces, and what are the significances of the oral foci of infection. So initially, as I told you, cellulitis, it's also known as phlegmon. Cellulitis is basically the spread of infection which is diffuse in nature. Diffuse means it's a widespread in nature. Initially, the odontogenic infection, either a periapical or periodontal infection, when it spreads, it involves the bone, that is the cortex layer of bone, and then it just involves the superficial surface, that is the skin. And the inflammation is not just confined to a particular area, it just tends to spread through a wider area, constituting the clinical features of cellulitis. So it is a diffuse inflammation of soft tissues which just tends to spread along the facial spaces. So the etiology is again either a periapical infection or a apical abscess, periapical abscess. Ultimately, after periapical abscess, it spreads to the bone, it involves the bone, becomes osteomyelitis, and again then it spreads. Or following a periodontal infection also, if the infection spreads and involves the overlying cortex, it leads to cellulitis of that particular area. So here you can see the clinical picture of a cellulitis. So it's nothing but the characteristic signs of inflammation are seen, that is the pinkish color erythematous area is seen, and it is very wide in appearance, and it is shiny, it is stretched. So this is cellulitis of leg. So when cellulitis of face and neck is seen, it is characteristically related to odontogenic infection, either a periapical or a periodontal infection. So we'll see the cellulitis of face and neck. Okay. So when cellulitis is occurring involving the head and neck region, the patient appears to be moderately ill. He has elevated blood temperature. Temperature of skin is elevated. He has symptoms of fever. He has symptoms of moderate leukocytosis is present, and whatever tissues are involved, they show a painful swelling, and because of inflammation, the characteristic skin appears to be stretched, and if the inflammation is involving the superficial tissues, it's giving a orange peel appearance. That is, the skin is stretched and shiny, and if the inflammation is involving the deeper tissues, the superficial tissues, they may be just of normal color, but they just manifest a swelling and pain in that particular region. So as the inflammation progresses, and it involves the regional lymph nodes, so regional lymphadenitis is present, and as the inflammation progresses, ultimately what happens is the discharge of whatever pus is present, it is just tending to spread along the facial spaces, and once it becomes localized, at one point of time, it tends to discharge through the skin surface. So the pus is discharged from the skin surface. So if it's involving the facial region, particularly the cellulitis arising from premolar or molar region, it involves the upper half of the face. And when it's involving the lower mandibular region, if the infection is arising because of lower mandibular molars, it tends to involve the bone and the regional lymph nodes, the submandibular, the cervical group of lymph nodes are affected at a faster pace than when in compared to the maxilla. And once the inflammation just spreads, it forms the abscess, and the abscess tends to drain itself through the surface. Though the clinical symptoms are very severe, the resolution of this cellulitis is very fast, as once the pus discharges from the surface and the clinical symptoms just reside. So this is the clinical picture of cellulitis, and when we see the microscopic picture of this cellulitis, is basically essentially one of a diffuse inflammation involving the polymorphonuclear leukocytes, lymphocytes, the plasma cells, and along with that the pus discharge is present, so obvious serous fluid and fibrin will be present. And if we see the etiology of this cellulitis is basically caused by microorganisms which are the potent producers of this hyaluronidase enzyme. And as far as we go, the oral microorganisms, the streptococcus are most common organisms which produce this hyaluronidase enzyme, and they are implicated in the etiology of cellulitis. And these streptococcus are more commonly seen in all of our periapical or periodontal infections. So we have seen the clinical features, histology, and the treatment for this cellulitis is nothing but administration of antibiotics. Prolonged antibiotic therapy is required, and once the pus is discharged, the pus may discharge on its own, or it may require an incision. So once the pus is discharged, the clinical symptoms just recede on its own. And the extreme case is if the patient tends to massage the area, that particular cellulitis area, it tends to get solidified. So patient should be advised not to massage the particular area. And in antibiotics, particularly anti-anaerobics are prescribed. There is one which are given for the gram-negative organisms are prescribed more commonly. So rapid resolution of symptoms are seen in case of cellulitis of face and neck. So now we'll see the infections involving the specific tissue spaces. What are tissue spaces? Tissue spaces or facial spaces are spaces are basically spaces present within the tissues. Shapiro, the author, he said that there are no such appearances of tissue spaces. Then whatever spaces are formed in facial infections, they are nothing but potential tissue spaces. That is, normally these spaces are basically, they are enclosing the submandibular gland, the nerve, the muscles. They are just enveloped by a loose connective tissue. And because of any infection occurring, this loose connective tissue, because it is very easily dispersible, it just tends to give way for the pus, and it appears that the inflammation or the pus is just spreading along these spaces. So these are called the potential tissue spaces. So we'll see what are the infections involving the tissue spaces. The infections in relation to the mandibular region or the lower jaw include the submental, submandibular, sublingual space, the parapharyngeal space, submasseteric space, the buccal space, the parotid space, pterygomandibular space, pharyngeal space, and the peritonsillar space. Okay, and when involving the maxillary region, we can see the buccal space, the canine space, the spaces involving the maxillary antrum, and the intratemporal space. So these are nothing but the space infections classification. Now we'll see the space infections one by one. As we know, the space, it's just a potential tissue space. It normally it encloses the gland associated with it, the muscles and the nerves of that particular region, and only when inflammation spreads along that, it appears to be that particular region or that particular space is showing a prominence of infection. Okay, the canine space is nothing but infection involving the region of the maxilla, that is the upper third of the face. In canine space shows swelling in the region between the anterior surface of maxilla and the levator muscle of upper lip. So between these places, whatever the infection is present, that's giving the appearance of a canine space. Usually it is upper face shows swelling, and the clinical features of swelling and obliteration of the nasolabial fold is present. Once the inflammation starts and pus starts accumulating, it also spreads to involve the eye, and serious infections like cavernous sinus thrombosis may occur if it is involving the orbital region. Sometimes what happens is the pus just tends to drain through the inner canthus of the eye, leading to resolution of the symptoms. Buccal space infection. So buccal space infection, what are the boundaries? Space is occurring, it is a normal tissue. It's bounded by all the muscle, the bone, the cartilage, the muscle, arteries, nerves. Within that, they are just surrounded by loose connective tissue, right? When it is, in cases of inflammation, it is just replaced by that particular pus. The loose connective tissue just gives away, and that leads to formation of space, the buccal space. It doesn't exist, but because of presence of the inflammation, the loose connective tissue just gives away, leading to formation of space in that particular area. So that's why the term spaces have been used. Okay, so the boundaries of the spatial infection, the buccal space infection are, it is basically bounded medially by the buccinator muscle. So one side you have the buccinator muscle, and the lateral side you can see the skin, the surface of skin is present. So medial boundary is the buccinator muscle, lateral boundary is the skin, and upper boundary, if we see the anterior boundary, it is nothing but the posterior border of the zygomaticus muscle. And when you see posteriorly, lower border, it is nothing but the border edge of masseter muscle is seen. So that forms the buccal space. And superiorly above zygomatic arch, inferiorly lower border of the mandible. So that those two represent the superior and inferior boundaries of the buccal space infection. So buccal space infection is basically concentrated from the zygomatic arch to the lower border of the mandible. That particular region shows presence of swelling, along with swelling, pain in that particular region, and swelling extends from the zygomatic arch to lower border of mandible. So here you can see the buccal space infection. So the characteristic appearance of a facial swelling, inflammation, and the buccal space, basically it is a dome shaped swelling. Okay, and along with the swelling of the involved face, the pus just tends to involve the eye. So there is a characteristic periorbital edema, and features of shiny appearance and discharge of pus from the facial surface are seen. So now we'll see the infratemporal space infection. Infratemporal space infections, as we know, the boundaries of infratemporal space are: above it is the maxillary tuberosity anteriorly, then posteriorly it is the lateral pterygoid muscle, superiorly again it is the zygomatic arch, inferiorly it is again the lower border of mandible, and laterally it is the coronoid process, and medially it is the lateral pterygoid plate. If you can see the picture there, clinical picture there, or the diagrammatic representation there, the infratemporal space, it's just located beyond the coronoid process of the mandible. Okay, and the infratemporal space is a potential space as it contains pterygoid plexus, internal maxillary artery, and all the nerves. That is the chorda tympani nerve, the lingual nerve, the buccinator nerve, and even the external pterygoid muscle. So all of these are associated with the inflammation or spatial infection in that particular infratemporal space. So there's associated characteristic features of inflammation, that is presence of swelling. Extraorally it is involving the sigmoid notch, and intraorally it is involving or extending up to the tuberosity region. Characteristic trismus is present, which is very severe because it is involving the lateral pterygoid plate and the lateral pterygoid muscle. So the trismus is little bit severe, leading to restricted joint movement of that particular area. And this space infection or the swelling, it may just involve the eyelids. Again, periorbital edema is present, and because it is involving the soft palate or the maxillary tuberosity region, sometimes inability to take food, that is dysphagia, is present. Okay, that's about the infratemporal space infections. Again, the lower border of infratemporal space, it is nothing but the pterygomandibular space. It is the inferior most part of the infratemporal space. And again, it is bounded, or it lies between the lateral pterygoid muscle and the coronoid process of the mandible, or the ramus of the mandible. The infratemporal space was between the lateral pterygoid plate and the coronoid process, whereas this pterygomandibular space is between lower part of the infratemporal space, right? So it is between the internal pterygoid muscle, lateral pterygoid muscle, and the ramus of the mandible. Again, initially the extension or the involvement of this infratemporal space or the pterygoid muscle, it may be because of odontogenic infection or a periapical infection or abscess involving the lower third molars, mandibular molars, lower second molars or the lower third molars. So infection from that region may extend and involve the spaces. And more commonly sometimes what happens is pericoronitis, that is involving the partially erupted third molar. If inflammation is severe, it leads to extension along the infratemporal space and the pterygomandibular space. So extension from pericoronitis is more common, and it is associated with facial swelling in that particular region or space which is seen in that boundaries. Along with that, presence of severe trismus and extremely radiating pain, sometimes involving pain in the ear and headache, is also seen. The clinical characteristic features of clinical facial swelling are not seen, not severe in case of pterygomandibular space. Yeah, they are seen in case of intratemporal space, but when they are involving the pterygomandibular space, the clinical facial appearance of facial swelling need to be minimal. The pterygomandibular space infections are more commonly seen during extraction of third molars or second molars, when you are injecting a local anesthetic into the pterygomandibular space, or if a local anesthetic is just injected into the maxillary tuberosity and there is some infection because of the during the injection, or that leads to inflammation and spread along this pterygomandibular space. Okay, there is a severe trismus here again in pterygomandibular space because it's involving the lateral pterygoid muscle, right? Severe trismus, inability to take food, dysphagia is also present. The lateral pharyngeal space, it's other extension of the pericoronitis or extension of the pterygomandibular space ultimately leads to this extension of submandibular space, also leads to this lateral pharyngeal space. Basically, it is bounded anteriorly by the buccopharyngeal aponeurosis and the parotid gland, posteriorly by the prevertebral fascia, laterally it is bounded by the carotid sheath, and medially by the lateral wall of the pharynx. If we see the submandibular space, it is situated in the lower jaw here, right? So extension from the submandibular space is the most common reason for inflammation in this lateral pharyngeal space region. It's involving the severe swelling and pain in the pharynx region, so invariably dysphagia will be present, and it leads to asphyxiation, that is restricted breathing because of involvement of the pharynx. Okay, and source of infection may be again a third molar, pericoronitis. Difficulty in swallowing may be present. Sometimes pain may also be referred to ear, and severe trismus is present because of involvement of the buccopharyngeal aponeurosis and involvement of the muscles of mastication. And the characteristic or the most significant features of this lateral pharyngeal space infection is that lateral pharyngeal space is the potential space which leads to spread of infection in different directions. If there is spread of infection along the mediastinum, okay, it leads to restricted breathing, or it may ultimately involve and spread to the mediastinum and other body parts. If the lateral pharyngeal space infection, it spreads upwards and it involves the skull and it involves the foramina, it leads to cavernous thrombophlebitis or the cavernous sinus thrombosis. That is again a serious complication of this lateral pharyngeal space infection, and ultimately meningitis may also occur because of involvement or spread of infection along the meninges. And the content of the lateral pharyngeal space is a carotid sheath, right? Even if it involves the carotid sheath, then thrombosis of the blood vessels is seen. That is also a serious complication. Okay, so the lateral pharyngeal space is a very dangerous or a potentially dangerous space infection. Okay, the retropharyngeal space is nothing but extension of that particular space, that is it's involving the anteriorly the wall of the pharynx and posteriorly the prevertebral fascia, same as the same as the lateral pharyngeal space, but it's the posterior extension of that particular space. And it also involves the laterally, it is just bounded by the lateral pharyngeal space and the carotid sheath. It is just medial to lateral pharyngeal space, we can tell like that. Again, the clinical features of swelling, pain, dysphagia, dyspnea are present, restricted breathing, and bulging of the posterior pharyngeal wall. And if the spread of infection occurs through the skull, mediastinitis is seen. If it is involving the carotid sheath, then thrombosis of the blood vessels is seen, cavernous sinus thrombosis is seen, and sometimes erosion of the internal carotid artery is also seen. These are the potential complications of a space infection occurring in the retropharyngeal space. The parotid space is another common space or a potential space where inflammation or infection can spread. So parotid space, basically it involves the parotid gland, the facial nerve, the auriculotemporal nerve, and the posterior facial vein, the external carotid, internal maxillary artery. These are the contents of the normal parotid space or the parotid gland. It is just bounded by this, the vein, the arteries, and the parotid gland itself. So how the infection occurs in the parotid gland? It's occurring because of a silent that is infection of either the salivary gland or extension from the periapical, periodontal or pericoronal infection or a periapical abscess. So once it involves the parotid gland or the parotid space, so the inflammation just spreads along all these structures, and ultimately it leads to occurrence of a swelling, though the trismus is not present here because this parotid gland, it is just relatively not attached by any muscles, so there is lack of trismus. Obvious swelling is present and obvious characteristic appearance of elevation of lobule of ear is seen. If the space infections of this parotid space, it just tend to spread along the parotid duct and involve the other areas, and sometimes the pus may be discharged either extraorally on the skin surface or intraorally into the floor of the mouth. And sometimes if you just massage the parotid gland or the parotid duct, the pus tends to escape from the opening of parotid duct in the oral cavity. And infections, these were the infections involving the lower jaw, or more commonly the potential space infections. Sometimes the body of mandible may show spread of infection, that is either a periapical or periodontal or pericoronal infection. It just involves the outer cortex of the mandible. For initially the thinner areas of cortex are involved, then the thick layer of cortex are involved, and it just involves the marrow spaces and tends to spread along it. Infections, these periapical infections may be of either of incisors or premolars or molars. More commonly, they present as a swelling in the labial or buccal sulcus, or they present as a swelling in the labial sulcus. Ultimately, they involve the cortex of the bone, they involve the marrow spaces, and the inflammation just so even the body of mandible shows the potential space. It's a potential space for inflammation to spread along. Now we'll see the submasseteric space infection. It is a space infection seen in the lower jaw. It is characteristically seen, that the space, the submasseteric space, it is bounded or it is seen between the masseter muscle and the lateral surface of the mandibular ramus. As you can see in the diagrammatic representation there. So the submasseteric space, it is just occurring between the masseter muscle and the seen on the lateral surface of ramus. So infections from a third molar, either a periapical infection or a pericoronitis infection, that just tends to spread and involve the space situated between the masseter muscle and the ramus. Okay. So a characteristic facial swelling is present. Along with facial swelling, because of involvement of the muscle of mastication masseter, trismus is present, and extreme pain, radiating pain is present. The patient is severely ill, he is just not able to open his mouth because of the associated trismus, and he appears to be extremely ill. Inability to take food may be the other common findings seen here in the submasseteric space. Okay. Submandibular space, it is just situated anteriorly, it is a triangular space, it is bounded medially by the hyoglossus and the digastric muscles situated. As you can see in the diagrammatic representation there, the green color radiating part, it just denotes the submasseteric space or the submandibular space. Okay, the green color part denotes the submandibular space. It is just a triangular space swelling bounded medially by the hyoglossus and the digastric muscles, laterally by the superficial fascia and skin, and it encloses the submandibular salivary gland and the associated cervical lymph nodes. So infection of this usually arise from the mandibular region, that is the mandibular molars may be the cause, odontogenic infection, or this presents clinically as a swelling near the angle of mandible. The space is here, right? So the swelling is involving the angle of jaw, and the abscess, it is basically triangular. It is associated with characteristic inflammation of the salivary gland, because the submandibular space, it's enclosing the salivary gland. There is infection of the salivary gland, it's enclosing the cervical lymph nodes. So there is infection of the cervical lymph nodes, lymphadenitis is present, and Potential dangers associated with this infection is that the submandibular space infection, it tends to spread and involve the lateral pharyngeal space, the carotid sheath, and involvement of from the carotid sheath, the infection just tends to spread to the skull, causing the meningitis or cavernous sinus thrombosis, or it may just directly extend into the mediastinum. So, there are the potential dangers associated with this space infection. Okay, sublingual space is nothing but a space infection present anteriorly. It is bounded superiorly by the floor of the mouth. Okay, it is seen here below the level of the submandibular space. Okay, superiorly it is bounded by the floor of the mouth. Inferiorly it is bounded by the mylohyoid muscle. Anteriorly by the body of mandible, and posteriorly it is bounded by the hyoid bone. So this seems to be the region for occurrence of this sublingual space. And abscess arise directly by perforating the buccal cortical plate because of a odontogenic infection. It just perforates the cortex of bone and just involves the cortical plate. And clinically you can see the swelling in the floor of the mouth, and associated elevation of the tongue is seen sometimes because it's involving the floor of the mouth, right? The swelling, it presents that the tongue appears to be elevated. Along with that, there is characteristic dyspnea, there is difficulty in swallowing, and dysphagia, difficulty in breathing and sleeping, both are seen. Okay, so these were the potential spaces infections occurring in relation to head and neck, especially the maxillary and mandibular regions. Okay, now we'll see other characteristic space infection, that is a Ludwig's angina. It is actually a very, very acute and a life-threatening space infection. It is characterized by involvement of all the three space infections, that is the submandibular space infections, the sublingual, and the submental spaces. So involvement of three spaces, submandibular, sublingual, and submental spaces is present, only then the term Ludwig's angina is given. It is basically a toxic cellulitis where there is diffuse spread of the inflammatory process along the three spaces. Initially it begins as a submandibular space infection, later on it spreads and involves the sublingual and the submental spaces. Again, the source of infection may be a mandibular molar, odontogenic infections, periapical or pericoronal infections, more causative of causing this disease. So the swelling, it involves the tongue, and it presents as a board-like swelling in the floor of the mouth. The swelling just is not circumscribed, it just is very, very diffuse and just tends to spread. And characteristic swelling in the floor of the mouth along with the elevation of the tongue, and clinical extraoral facial swelling involving the neck region. Here the swelling is very, very firm, it is extremely painful, it is diffuse, and the characteristic brawny edema is seen. Okay, and the inflammation just does not give any symptoms that it may be localized. It is we have such diffuse nature. There is large swelling present in the lower region of the neck, or it's involving all the spaces, right? The submandibular, sublingual, and submental, which are situated here in the lower region of neck. So there is a characteristic very, very huge swelling in the neck region, and the swelling is very diffuse. The patient has difficulty in eating and difficulty in breathing also because of elevation of the tongue on the floor of the mouth. The patient has difficulty in sleeping, difficulty in eating, dysphagia, dyspnea is present, and characteristic symptoms of high fever, rapid pulse, moderate leukocytosis is present. Along with that, the respiratory rate of patient is increased, and because of involvement of neck region, the swelling may also involve the glottis and epiglottis, leading to restriction in eating and swallowing, even breathing. And if the spread involves the lateral pharyngeal space, if the inflammation is involving the lateral pharyngeal space or the parapharyngeal space, and it's a dangerous one because these infection can just involve the carotid sheath and spread to either the skull, causing cavernous thrombocyanosis, or mediastinum directly. So treatment for this Ludwig's angina, initially it involves maintenance of airway because of the characteristic respiratory obstruction this Ludwig's angina swelling is causing. First attempt should be maintenance of airway. Either a tracheostomy may also be indicated if swelling is very severe and the patient is just not able to open his mouth, and intense and prolonged antibiotic therapy is required. And along with that, drainage for this is very, very essential. It does not tend to drain. Ludwig's angina, when it involves all the three spaces, it does not tend to show any symptoms of drainage on itself or pus drainage through the surface. So you have to just carry out drainage, incision and drainage procedure to relieve the pus, and whatever offending tooth has been identified as the cause of causing this Ludwig's angina has to be just extracted, and surgical drainage is must in this case of Ludwig's angina. So these were the common space infections we have seen. As it has been proposed previously by all the authors before 20th century that oral organisms or the oral microorganisms are responsible for causing a lot of systemic diseases. So the presence of some focus of infection at a distant site may lead to symptoms in generalized body. Like the oral foci, it is the presence of microorganisms in the oral cavity. It is causing systemic symptoms like arthritis and other diseases. So before the advent of microbiology as a separate disease, so it was thought that oral focus of infections are responsible for even for causing systemic diseases. Now it tends, even though now the microbiology is developed, still the oral foci theory is being followed. So what is a focal infection? A focal infection is nothing but a generalized or systemic infection caused by dissemination of microorganisms or dissemination of toxic product produced by microorganisms. So there are basically two ways where the inflammation or infection can spread. One is the hematogenous route, that is the microorganisms themselves are carried to the distant site causing the systemic disease, or the toxic products produced by microorganisms, they are just transmitted to other sites, transferred to other sites causing the disease. So for obvious spread of the infection, some focus should be present. This focus is the site where all the exogenous products or the toxic products are concentrated. So focus of infection refers to circumscribed area of tissue which is infected with the pathogenic microorganisms, and it becomes as a potential site for the microorganism to persist there, and from there the toxic products are liberated into the bloodstream and carried to a distant site, causing infection at various places. So what are the oral foci of infection? As we know, odontogenic infections, there is a periapical infection, initially beginning with pulpitis, again causing a periapical infection, periapical abscess. They may be the commonest sources for infection from the pulp, and along with that, infected periapical granuloma, cyst or abscess are the common source of infection, and even the teeth which are having which have undergone root canal therapy and are still infected are the potent producers of this toxic microorganism products. And periodontal disease, though it is of diffuse nature, it involves a lot of anaerobic microorganisms, so those are also the sources of disease, oral foci for causing a systemic disease. Okay, so the basic two mechanisms: one is the hematogenous or lymphogenous spread of microorganisms directly. Second is the spread of toxic microorganisms or toxic products produced by the microorganisms to a distant site, leading to a hypersensitivity reaction to that particular toxic product. So two mechanisms for the spread of infections occur. And so oral foci of infection, as we have seen the oral foci of infection, the periodontal or periapical or whatever infection source of infection are present, they are seen to cause or aggravate the systemic diseases. Yeah, systemic diseases may be present, they are just aggravated by this oral foci of infection. Arthritis of the rheumatoid arthritis type, initially it was thought that arthritis, because rheumatoid arthritis, it is basically caused by some forms of streptococci, and streptococci are more commonly seen in the oral cavity. So it was thought that streptococci microorganisms are the oral foci are present in the oral cavity, and they are spreading to a distant site and causing swelling of the associated joints and inflammation of the joints and swollen joints, leading to restricted mobility of the joint. So streptococcus, which has oral origin, oral foci of origin, was thought to cause arthritis, okay, because of spread of infection or spread of microorganisms to a distant site, causing a hypersensitivity response. Whereas subacute bacterial endocarditis is nothing but the accretion or the deposition of alpha hemolytic streptococci on the valves, the mitral valves, the tricuspid valves. They show deposition of this alpha hemolytic streptococci leading to some valvular heart disease. So the organisms are basically the streptococci. These streptococci are again commonly present in our oral cavity. All forms of streptococci are seen. So again, the authors related that the oral foci, that is the streptococci which are present in oral cavity, were just transferred to a distant site because of bacteremia. Bacteremia is nothing but the process of dissemination of microorganisms. Even when you are carrying oral procedure like extraction of a tooth, during extraction, what do? You just tend to use a forceps and mobilize the tooth initially before you extract it from the socket. So that mobilization or rocking of the teeth also leads to bacteremia, and that bacteremia leads to spread of infection, and that because the children are already affected with a rheumatic fever initially when they were young, and when this kind of bacteremia occurs, the streptococci just tends to localize on the valves of the heart and cause the valvular heart disease. So even bacteremia may also be seen in cases of normal procedures like scaling of teeth or any procedure which involving the where you are involving incision of the mucosa, or where there is blood involvement. Wherever blood is involved, you can expect that the bacteremia is occurring, and it leads to this systemic disorder. So even some forms of skin diseases like psoriasis or eczema were correlated with presence of oral foci of infection. That is, some microorganisms were correlated between the oral cavity and that disease, but it's relatively insignificant now. So this was the previous theory, oral foci of infection, which is now even today well accepted, especially in cases of subacute bacterial endocarditis. So you have to just take care that whenever you are carrying out a procedure in a patient of rheumatic fever, you have to just keep the patient under antibiotic therapy whenever any surgical procedure, oral surgical procedure, especially extractions, are carried out.